So good evening. Hello.
Hello, good evening.
Oh, hi. How you guys doing? Well,
Good.
I hope you guys enjoy your weekend. And we are back again with this anatomy and physiology. We are going to continue with the nervous system, the second part of the nervous system, and see how far we can move on with this chapter. Okay. Do you guys have any questions?
Not right now.
Okay. That sounds good. Let's then begin with this module and see if we can. We are almost halfway. So next week, Wednesday, something like that, I believe we are going to be finishing it. So we're moving on. Okay, so we continue with the nervous system, which is the senses. The senses are a very, very important subject. So we need to understand um, how our eyes function, what the structures of our eyes are, the ears function and structures. So that's basically what this chapter is going to be all about. Knowing a little bit, learning a little bit about the senses. So let's see how far we can go. Not only the eyes and the ears, but those sensors for um, touch, pressure. So that's basically what we're going to be doing here. So let's talk about these sensory functions. Well, we have receptors. The senses are made of cells that are called receptors, and those receptors are the ones who are going to tell what type of sensations or sensories are we are perceiving, whether are the sensors of sight, hearing, taste, or touch, feelings. When we feel something on our skin, how do we feel that? What sensors captures all these stimulus? Once again, they might be from the inside. They can also be from the outside of our body. So these sensor receptors are divided into groups or two types. So let's start with general senses. So here we have the general senses. And the second group, this will be the first type of group, and the second group will be special senses. Very simple. General senses are all those receptors that we cannot see. So these receptors are spread all over our body. They are distributed through our body. Skin, organs, joints, you name it. These receptors are there. So these are very, very small receptors. That's what it's called general, because they are all over our body. Think about the pain receptors. We don't see them, but these are receptors. These are considered general receptors. Temperature receptor, thermoreceptors. These are the receptors located anywhere in our body. So whenever it's hot or it is cold, these receptors are going to capture those stimulus, but they are everywhere. You don't feel cold only in your hands or in your feet or in your head. If it is cold, you're gonna feel the cold through your whole body. The same with the pain. Of course, the pain, we're gonna feel it in certain areas of the body, wherever we have the trauma, the infection. But then this pain is gonna be sent to the brain. And the brain is the stimulus is gonna be sent to the brain, and the brain is gonna tell us that we have some type of pain. And we feel it like in general. Touch receptors, the same. When somebody kind of put their hands on us, or we kind of hit part of our body against something due to a fall or to any other type of trauma, we're gonna have that stimulus in our body, in any part of our body. If I hit my head, the pain is gonna be in my head because we have those receptors there. If I hit my legs, my arms, any other parts of the body, receptors are gonna be there. So that's basically what general receptors are. Now, special receptors, on the other hand, these are large structures. These are structures that we can see, we can touch, and we have them in certain areas of our body. For instance, your eyes are only located right there in front of your face. We don't have eyes anywhere else in our body. That's what's called special senses. General, we have it everywhere. That's what is called general. Special, these are large organs and very specific structures in certain areas of our body, and we can see them. I can see somebody else's eyes, but I cannot see the receptors of pain, touch, temperature, chemicals. I'm not gonna be able to see them, but I can see your eyes. I can see your ears. I can see your nose. I can see your mouth, or more specifically, your tongue. So these special senses are large organs. We are able to see them, to touch them, and they are located in certain particular areas of our body. And if you see, most of them are located within the cranial or the facial cavity. Ears, eyes, nose, and mouth. So those are special senses. So once again, these senses are divided in two types or two groups of sensory receptors. Some of them are very general because we find them everywhere on our body, or we find them in certain particular structures of our body. Because we find them in certain areas, in certain particular organs or structures, we're going to call them special. But if they are everywhere, they are called general. So think about that. That's how you are going to recall these. Let's talk about first the special sense. So we are going to talk about smell, taste, hearing and equilibrium, and sight. So when we talk about smell, we immediately relate it to the nose, to that second cranial nerve, the olfactory nerve. See, those are the ones in charge of the sense of smell. and it's located within the nose, within the mucous membrane inside the nose, the nasal cavity. That's what we call, see, smell, nasal cavity. But these are the olfactory organs, because remember we covered the olfactory nerves, and olfactory means smell. So that's basically what it is. Then we're going to talk about taste. We are talking about oral cavity, but most particularly the tongue. Remember, that's basically what it is. Within the tongue, we're going to find these taste buds. Right here, the taste buds that are the one that captures the stimulus of whatever chemical we are eating or drinking. So they capture this flavor, the taste, whether it's bitter, whether it's sweet, whether it's salty. So whatever the case may be, these receptors within the tongue are going to tell us what is it that they are capturing there, which chemical receptors are there. So that's basically what it is. So we have hearing and equilibrium. So that will be these receptors that help us out to hear mostly. Not going to focus on equilibrium, but there is something related that we will discuss later on. But hearing is the most important thing. These auditory receptors, and those are located in the inner ear. We're going to see the structures of the ear, we're going to see the structures of the eye, and we're going to see in which areas of the ear, the eyes, the nose, the tongue, we're going to find these special receptors that give us like the signals of what they are capturing there, whether it's taste, smell, or whatever we're hearing, or whatever we're seeing. So that's basically what it is. Sight, eyes, or we can say the vision, if you will. So these are basically these particular special senses. So once again, they are large structures. They are located in certain areas of our body, and we can distinguish them easily. We don't see the receptors of smell, taste, but we have the organs where they are located. And we always only gonna have receptors of smell within the nose, taste within the mouth, hearing within the ears, and sight or vision within the eyes. Once again, we don't taste anything with any other part that is not the tongue inside our mouth. So that's what we call then special senses, because they are special organs in our body. Let's start with sense of smell. Olfaction. Remember, we need to understand these medical terms because we are in a class related to medical. Olfaction, olfactory, smell means the same. So for the public, for the general population, we're going to use smell. but it is the olfactory or the olfaction senses. So that's basically how it's called. We're gonna have these olfactory receptors. Here they are because we're talking about olfaction or the sense of smell. So it is made of these receptors, the olfactory receptors. All the olfactory receptors are chemoreceptors. So what do you mean by chemoreceptors? These are chemicals within the mucous membrane inside the nose that captures the smell. Remember, when something smells, whether it's good or bad, these are chemicals that are released from these particular sources and they come in contact with our mucous membrane. So this is mucous membrane is the soft part inside the nose, like the gums inside our mouth. Very soft tissue inside the nose, and over there, this soft tissue that is called the mucous membrane contains these chemoreceptors. They become active when they smell something. So that's basically what it is. When they come in contact with this smell, they immediately tell the brain, what is it that they are smelling? Remember that our body gets accustomed of smells. If you smell fish from the distance, you immediately recognize that that is fish, that is something else that you're familiar with. So when you pass by a restaurant, you smell some food. Then you start like craving, salivating, because it triggers those receptors of taste as well. So olfactory and taste receptors, they are connected. But if you smell something bad, you immediately, your brain tells you that something really smells bad. And we recognize those smells. Even though if you don't know where they come from, you know, because due to those chemoreceptors, that smell is not something that we wouldn't smell. And if it smells good, it is something that you also recognize that smells good. That's basically what it is. So olfactory receptors are chemoreceptors. So are these chemicals from these different sources that producing that smell are the one that enters through the air, through our nostrils, the openings on our nose, and these receptors inside the mucous membrane are going to capture this smell, these chemicals. And it's going to be translating them to some bad or good smell. So that's basically what it is. And our brain already have in its memory certain chemicals, certain chemoreceptors related to the olfactory senses or smell. That's why you know when you stop by a gas station, smells gas. But if you smell that gas or gasoline somewhere else, you're gonna recognize it. The gas from your home, when you open the stove, you smell that gas. It's very characteristic and you know it. If you're cooking some eggs or if you frying some chicken or some fish, you're gonna recognize those smells. Remember, we have some part of the brain that stores the information, memory. And when we go back and we encounter these chemoreceptors again, it's going to come to our brain, and our brain is going to interpret those, and it's going to say, hey, I have been exposed to this before. This is like when you see someone, you might not remember his or her name, but you do recognize their face, or probably their tone of voice. Said, oh, wait a minute, I think that I know this person. I've seen it before. I don't know where, I don't remember where's the name of the person or place when I met this person, but I do recognize this person. Because we have this part of the brain, once again, that stores all this information, all these memories. Well, sense of smell, it's not an exception. It also stores information about smell. So here it says the olfactory organs. We talk about the receptors first. These are the chemoreceptors. And here we have the olfactory organs. So these are these large structures. So it says right here, cover the upper part of the nasal cavity. So superior nasal concave and a portion of the nasal septum. So concave is all these opening inside the nose that is covered by the mucous membrane. That's the reason why when you blow your nose too many times, it gets irritated and sometimes you bleed from it. This is a mucous membrane. It is tissue, it is soft tissue. And through this soft tissue runs nerves and blood vessels. Very tiny blood vessels that are on the surface of this mucous membrane. So if you blow your nose too much, too frequently, you're actually gonna damage those little blood vessels, these capillaries on the surface of the mucous membrane, and you're gonna bleed. Or when you pick your nose, start putting something in there, you're gonna bleed because it's a mucous membrane. And if you have an infection, you have the flu, you have the COVID. Remember with the COVID that you lost sense of smell because this virus kind of inflame inside, cause swelling inside the mucous membrane. And when the mucous membrane swells up, it loses its capacity on the surface of the receptors. The receptors are sent deeper because of swelling. So you're not able to smell. So that's basically what it is. So whenever we have some type of upper respiratory infections, we lose these senses of smell. But here they're just telling us the receptors, the things that we cannot see, and the organs, the large structures that makes up the smell organs, which is the nose once again. But inside, it's not the outside of the nose where the receptors are located. Nasal septum, said right here. So we talk about the mucous membrane, which is the superior nasal concave. So all the mucous membrane that lines the inside of the nose, that's the mucous membrane that makes up the superior nasal concave. The nasal septum is that particular structure that separates the right from the left nostril. So there are two little openings in front of our face by the nose. But there is a wall right there that separates them. That's called the septum. Remember, this is like, well, we will talk about that when we get there. So that's the septum. This is like this bridge that separates the right from the left nostril. But that is also covered by mucous membrane, particularly the part of the upper part that is lining up with the concave. So that's basically what it is. So it is important to understand these senses, because whenever you get sick, remember, you might wonder why is it that you can smell. So that's basically what it is. When we get to the tongue, we're going to talk about something similar. What is it that you cannot taste something? So if somebody smokes cigarettes, nicotine damage the mucous membrane of the nose. If you do drugs, like for instance, needs cocaine, that completely destroys all the mucous membrane. So you will lose your sense of smell, 100%. So once again, there are many things, fumes, chemicals. If you get exposed too many times to these fumes, chemicals, you don't wear a mask in certain places where you work at, you spend time with certain fumes or chemicals, you're gonna damage the mucous membrane. So that's basically what it is with the senses or the sense of smell. Any questions about the sense of smell? Good. I'm gonna go easy on this one. I will tell you what is really important for you to know about these senses. Now we have the sense of taste. Now this is called gustation, because this comes from the gustatory, gusto, taste. So gustation, sense of taste. So it says right here is the sense of taste. But what is it that provide us or allow us to taste something? Well, the same like the receptors from smell. We're gonna have some taste receptors. And where are those taste receptors are going to be located? Within the tongue, on the surface of the tongue, I might say. That is called the papilla of the tongue, which is the upper part of the tongue, not underneath the tongue. It's on the upper part. A little farther up, we have some, next slide, we're gonna have an image of the tongue, and I'm gonna show you how the papilla looks like. And where are these papillary taste buds are located? Because they are not all over our tongue. They are in certain areas of the tongue located. It says right here that we have about 10,000 taste buds. So those little spaces within the tongue where these chemoreceptors are located. So these are called chemoreceptors, just like the receptors of smell. They are chemoreceptors. We smell, we taste those things that we put in our mouth, and then these chemicals are being translated to the receptors. They move to the receptors translate the taste, and the brain let us know what exactly is the taste of these particular things that comes in contact with our tongue. That's basically what it is. This is very important for you to know. Taste cells are replaced every 3 days. See these cells on the upper part of the tongue? They are replaced by new cells every 3 days. Now think about this. When you burn your tongue, you eating something hot. It happens to me. I believe it happens to most of the people. So when you put something that is very hot, you don't do it intentionally. We're just hungry sometimes. Sometimes we just think that it's not that hot that we can take it. And if we burn our tongue, think about this. We burn it, but few days later, the taste comes back to us. This burn on the tongue goes away. We don't have to do anything. Do you put any creams on your tongue? Do you put any medications in there? I don't think so. Because these cells on top of the tongue, they are replaced, new ones replaced every 3 days. So this is the only place where these cells are replaced so often in so short period of time. So that's basically what it is. So taste receptors. Remember, smell and taste are called chemical receptors. These receptors from smell, from the nose and from the tongue are in touch with chemicals, whether through the fumes that enters our nostrils or something that we put inside our mouth. That's how we are going to discover, to realize, to interpret the types of chemicals that we are getting in contact with. So that's basically what it is. So for you, right here, just know there is a taste of smell. Remember, it's called olfactory. There is a taste, I'm sorry, there is a sense of smell that's called olfactory. There is a sense of taste that is called gustation. So whenever you have a question, gustation is related to what? Taste. That's basically what they ask. Olfactory, that is related to what? Smell. They're not going to ask you these particular receptors. But it's a good thing to know, just in case, because remember, those questions are continuously changing on exams. We don't know what the question is going to be this time. So they might add a different question. And one of those questions might be something like this. Once again, remember that the sense of taste and the sense of smell use chemical receptors. Here we have the tongue. Now, I don't know about you, but I have checked my tongue. I look my tongue and I see all these little like structures that the tongue is not completely soft on top. If you see your tongue like with magnifier glasses or somebody else's tongue, and if you look that tongue on the surface, on the upper part, you're gonna see a little things on top. Looks like you have tiles in there. Well, that is called the papilla. And that is the place where these taste receptors are going to be located. Right here, see, these are like little things. This is just a sagittal cut of one of them, but we're going to see all these little circles right there that looks like tiles on top of the tongue. Once again, it's not completely soft. We can see it right here. And we can see it right here on the sides and on the back. On the center, we don't have them. Now look at the image right here, this graphic. It has some spaces right here, mark. It has some spaces right here on the tip of the tongue, on the sides, and on the back of the tongue. Right here within the center, we don't have any of those receptors. So the receptors are on the sides and on the back of the tongue. So that's how they are located. And remember, within these papilla, these little structures on the surface of the tongue, kind of a little raised from the tongue because it's not completely flat, that is where the taste receptors or the taste buds are located. So that's basically what it is. But it doesn't end right there. Each one of these sites is going to tell us what chemical receptors we have there. Where are the sweet receptors located? Where are the salty receptors are located? Where are the bitter receptors are located? Where are the acid receptors are located? And so on and so forth. That's basically what is important. When we eat something that is sweet, the part of the tongue that is going to capture that taste is going to be on the tip of the tongue. It is the tip of the tongue that have the sweet receptors. So that's basically what it is. So not that everywhere we're going to have sweet, salty, bitter receptors. No. So we're going to see it right here. 5 primary taste sensations. Now, the last one was just added to. It wasn't there before. So every single time, remember, technology advances, new discoveries, new research. So sweet or carbohydrates. Remember, carbohydrates and sweets is the same. Carbohydrates. So if you have a question when they ask you, well, where are the carbohydrates taste within the tongue? That will be the tip of the tongue. Remember, go back here. So that will be here. This is the tip of the tongue, right in this area. Oh, this is not doing anything. Right here in this area. Whatever we have here in the tip of the tongue, that is sweet. That is sweet. What is on the sides? Back. Okay, we're gonna move forward. Sour. This stimulates by acids. So that will be this part. Oops. This is sour. Right here. Sour. It's on the sides. Going towards the back. Next, salty. Salty is right here in between sweet and sour, right here on the side. Bitter, right here on the back. See, S, S, and S. All the S are together. Sweet, salty, and sour. And the bitter is on the back. Those are the 4 receptors that we have back in the days. Then they add the new one, umami. This is the one. Now this is for proteins, amino acids. So we're going to find them spread all over the place except the front part, the tip. So they would be around here, in this area, in this area. And the spices as well. So that's basically what it is. But most of the time when they ask, if they are going to ask you a question, it's about the sweet, because it's always going to be on the tip of the tongue. So right here, spicy foods activate pain receptors. So whenever we have pain receptors everywhere, remember they are very general. And we have those pain receptors as well in our tongue, in our gums, in our lips, and on our skin, everywhere. So whenever you eat something that is very spicy, and because it burns, this is a burning pain, so it's going to be captured by these pain receptors. Here it says taste receptors undergo rapid adaptation. What do you mean by that? It means that whenever you are not used to eat something, say, let me give you an example. I don't like spices. Never used, back in the days, I didn't eat spices. We don't like spices. In my country, we don't prepare things with spices. If you go to a restaurant, they don't prepare things with spices in. They add it. They give you extra on the outside, on the side. If you want spices, they put it on the side. But they are not mixing up with the food that you buy. Because we don't like spices in my country. Meaning it's not mixed with the food. They put it on your side. Okay, do you like spices? Yeah, what is it? Okay, they're gonna put it on the side. But there are certain countries that they mix the spices with the milk. Well, I have some friends from India. They like to eat spice food. I don't. So when they invite me to eat, I don't eat. So they feel uncomfortable because, well, they invite me and now I'm not going to eat anything from them. So they feel very uncomfortable. And then my friend says, oh, well, he doesn't eat spices. So sometimes we stop by a restaurant and I bring something that I like to eat. One day they said that they will prepare something without spices. But for them was not spicy. They said it was mild. But the truth was that for me it was very spicy because I'm not used to at all to eat spices. But I ate a little bit. It was horrible for me. I had to drink milk. They gave me yogurt, milk, water, ice cream. You don't even know how many things I have because that thing was very spicy for me. According to them, that was it. Anyways, just to let you understand, the adaptation means that you adapt to certain things. That is basically what it is. Then I ate a little more mild food because I felt very uncomfortable bringing my own food and not eating their food. So I tried to stop not going, but they are my very good friends, so I just go there. So they start preparing something that was really mild. Well, because some of the food comes already with the spices, so they couldn't remove it. I got used to it. Some of the little spices, it was very mild. I didn't react like the first time. So that is called adaptation. When you adapt yourself to certain chemicals, then you recognize them very, very easily. So that's basically what it is. You know when it is, the taste of peppers, um, cinnamon, um, some other, chemicals. You kind of, well, salty, you definitely, sweet, definitely. But with something is like not sweet, not salty, it's like sour or kind of bitter. You put together all these things that all the information that you have in your brain or things that you have eaten prior, and then you just kind of give a definition of what exactly might be these chemicals that you are ingesting. So that is adaptation. Our tongue, the smell as well. Some people, you enter to their house and smells weird, but for them, they live there, they are accustomed to it. So they think, no, I don't smell anything. Oh no, I smell something, I don't know. And sometimes I try not to breathe and I try to leave the place as soon as I can. And definitely I try not to come back unless it's really, really necessary. But you have entered somebody else's bathroom, particularly restaurant's bathroom. It's not like someone just left the bathroom. No, it's like they haven't smelled. Bad smell sometimes. Or the smell of those stuff that they put over there to kill the smells that actually are worse. So again, that is adaptation. We adapt to certain smells. It's like we adapt to certain places, to certain temperatures, to certain conditions. Well, we are very adaptable, if you will, to many circumstances. Well, these chemicals are not an exception. So that's basically what it's trying to tell. So once again, there are 5 primary taste sensations. Once again, but the most common ones are sweet, sour, salty, and bitter. And you see that 3 of them starts with the S, and we are very, very familiar with those. We know what is sweet, sour, salty, or bitter. Umami, well, not so much, because you don't know, okay, what do you mean this is taste of a protein or amino acids? We are not. But scientifically proven, after research and all the stuff, well, they discovered. So that's basically what it is. So you don't have to be too fond on that or too keen on that information. Just know sweet, sour, salty, and bitter, particularly sweet, if you ever encounter this on your exams. Usually, no. But just be familiar with sensation of taste, gustation, remember gustatory, smell, olfactory. Those are more prone to be asked on exams versus the taste buds. Well, the taste buds, where are the taste buds located? Oh, as soon as you see the word taste, you know that they are on the tongue, right? Over the tongue. Any questions about taste or smell? Gonna move to the sense of hearing. The ear. This is the organ of, well, Actually, it's not. The ear is not the organ of hearing. It's just in general that they say that. But let's put it away for now, because there is an internal structure inside the ear and the middle ear that is called the organ of hearing. So that's a very, very different thing. But they said here in general, but actually it's not the right expression right here to say. Okay, so let's move on with this. 3 sections of the ear. Outer, or the external ear, which is the external ear canal, plus the pinna on the outside. We're going to go over that. The middle ear, and the inner ear or internal ear. So 3 parts, because this is a structure. See, when we talk about the receptors, we don't mention the parts of the receptors, but we do mention the parts of these large special senses. So let's see right here, this image. It's important for you to understand. This is the outer ear. See, it's not just what you see on the outside, but all these up to here. This is the outer ear. That's it. It's large because it's not just the outer part that we see that looks like a little antenna on the outside. No, it is the little opening that it is within this structure where we put the Q-tips, which is called the external ear canal. All is this the external ear canal. So this part right here on the outside, where you put your ear rings and all the stuff, well, that is called the auricle or the pinna. Sometimes they say the pinna. Well, you can say either way, auricle or the pinna, or pinna, either or is correct. It says right here that it is a funnel shape. Yeah, it looks like a funnel. See? And from here, the sounds enter through this ear canal. And the sounds goes all the way in. See? It collects sound waves because it's like an antenna. So when the sound comes to, hits this pinna or pinna, immediately redirects them inside. So that's basically what it is. So that will be the auricle or the pinna. Let's put it the pinna for now, not saying 2 things at the same time. Pinna, pineapple, I don't know, something else. So that's basically what it is. So this is the external ear canal. This structure right here, external ear canal. Right here, we put the Q-tips. When we get the airwax, it says right here, contains ceruminosus glands. Cerumen is the name of the wax, the earwax. So pay attention to this name because usually they come in exams. Cerumen or ceruminosus, that means wax, earwax. Remember, our ears produces earwax, which is due to these ceruminosus glands. Inside here, we have these glands that produce wax. That's why we have wax inside our ears. And what do we produce this wax? because this is a protecting barrier for the ear, the external ear. That is basically what it is. So it is important to have wax in our ears. It's just that sometimes our ears produces too much. When it produces too much earwax, this earwax comes out by itself. At night when we sleep, when we turn and toss on our beds, and lean one side, lean the other side, the wax comes out. It's very, very little stuff coming out from there. When we take shower, they come out. When we walk, when we do some things, they come out. The problem is that sometimes we're gonna clean our ears. We're gonna remove everything that is there, and we put Q-tips in there. And instead of removing it sometimes, what we do is we push the cerumen and we cover the tympanic membrane that is right here. We push, and we make a huge hug right here of wax. And that is difficult to be removed. That's why sometimes you can hear from one ear because wax is there. Because we put Q-tips and we don't know how to clean ourselves. So what we do is we push all this wax from here to the end, to the deeper part of the ear. So that's the external ear canal. Now it says right here, at the end of the external ear canal, we have the tympanic membrane. Remember, when we talk about medical terms, tympanic, that's the eardrum. Remember, that's the eardrum. This tympanic membrane needs to be clear of wax. So if we have these wax right here blocking the sounds, we're not going to be able to hear well. Or maybe we're not going to be able to hear at all. That's why sometimes we have headphones or these earbuds or whatever the case may be. We don't hear anything because we're covering the external ear canal. So we don't hear what's going on the outside. Same happens if you have wax accumulated right here close to the tympanic membrane. You're not going to be able to hear. What is the function of the tympanic membrane? Remember this channel right here, which is the external ear canal, is a canal that receives all the waves of the sounds. But they come here and they encounter the tympanic membrane. So the tympanic membrane is going to be here. I'm going to change colors so you can see the tympanic membrane right here. So this is the tympanic membrane right here. It's like a curtain that separates this external canal, the middle ear. So when the sounds enters right here, the wave sounds, they don't know where else to go, right? So these sounds hit this membrane and these membranes start vibrating. That's how it is. Starts vibrating because it's trying to pass all these sounds to the next structure, which is the middle ear, and then pass it to the inner ear, and then send it to the brain, to the temporal lobe, which we have those nerves that translate sounds. So it is a process. We are a perfect machine. So these sounds from the outside, like right now, I'm talking to you, you're listening to me. So these sounds goes through your ears. they hit that tympanic membrane start vibrating and start sending the sounds to the middle ear, and then to the inner ear, and then to the part of the brain that translates these sounds, and it's going to tell you, oh, Professor Hoyer is saying this, or that, or he's talking about something that I don't understand, or yeah, I got that, oh, I wasn't familiar with that. I didn't know that, but now I understand why this or that happens. Because you're listening. All these sound waves are going through your ears to this external canal. Once again, hit this membrane that is like a curtain right there. Have you seen that when there you have your windows open and you have curtains in there and the air enters, the curtain starts vibrating, moving, waving. Well, similarly, this tympanic membrane or eardrum does when these wave sounds enters the external ear canal and it hits the tympanic membrane. Now these sounds needs to pass to the next level, which is the middle ear. So that's basically what it is. Up to here, everything is very basic. It is easy to understand. Now, the part that is difficult is going to be the inner ear. Why? Because the external ear and the middle ear, these structures can be fixed easily. If you have damage to the external ear, we can fix it, we can repair it. Surgical doctor can do that, plastic surgeon. If the tympanic membrane is broken, they can fix it. If something in the middle ear that damaged, they can fix it. Oh, but if something in the inner ear is damaged, we cannot fix it because that has to do with the nervous system directly. And the nervous system is very difficult to be repaired. That's why patients who were born with deafness, they're going to be deaf for the rest of their lives because there's no way we can fix it. Not up to now. They're trying. They're doing a lot of things to fix this. This is like a person who were born blind. It doesn't matter what you put on your eyes. It's not going to make you see anything because it's the nerves that transmit these impulses to the brain. This part of the brain is not responding to it. The other structures are fine. If it is cataract that you have, that can be fixed. If you have glaucoma, that can be fixed. If you have myopia, that can be fixed. If you have hyperopia, presbyopia, can be fixed. But if you have a macular degeneration, sorry. If you have a retinal detachment, sorry, nothing we can do for you. See? Something that happens within your brain is so difficult to be fixed versus something that happens with your heart, with your kidneys. See, we can replace your kidney. We don't replace brains. Have you heard about brain transplant? Maybe in movies, right? Not in real life, because the nervous system is very complex. There are many things that we don't know how they happen. So if we don't know how they happen, how are we going to fix it? It's going to be very, very difficult because it's a very, very complex system. And the problem is this is the system that we use for almost everything. Our body does not function without the nervous system. Because the brain is the one that controls every function of every single structure in our body. So think again. You know this, you've seen people that are deaf, that are mute, that are blind, and they're gonna die like this because no other way. They have to come up with other things to help you, but you cannot regain the functioning of these organs if it is the nervous system that is being damaged. So this is the external or the outer layer of the ear. Any questions about what I just explained about the outer or external ear? Okay, moving on then. We're gonna move to the middle ear now. Remember, we go from the outside to the middle to the inner. From the most, well, from the easiest part to the most complex part. The middle ear. So let me mark what the middle ear is. Is this green part right here that shows. This is the middle ear. That's it. This little piece right there. So here we have the auditory ossicles. Auditory means sounds, hearing, right? Ossicles. Ossicles means bones. But these are very, very tiny bones. It says right here, 3 tiny bones. Now, this is a question for the national certification. It can be 2 or 3 questions out of these bones. Where are the smallest bones in our body located? Well, the answer is the ear in general. But if they don't give you the ear, you have to look for the middle ear. Remember. So the smallest bones of our body are located within the ear, inside the middle ear. Let's talk about the names of these tiny bones. So remember, they're going to ask you, where are the smallest bones of our body located? The answer might be the ear. If they give you the ear as an answer, they're not going to give you the ear, the middle ear, the sternum. No, they're not going to do that. They tell you whether you're going to see one simple, single answer, whether it's going to be the ear or the middle ear, not both answers in one question. Unless this answer is in the same question. In the ear, within the middle ear. Well, it's a little redundant, but hey, just for you to understand. These are the smallest bones of our body. What are the name of those bones? Well, they have 2 names. Malleus, incus, and stapes. Pay attention to these. Malleus, incus, and stapes. Because they kind of look alike. Malleus is like a hammer because we have it right here. See, hammer, malleus. Incus, anvil. It's like a tool, farmer's tool. And stirrup, which is the stapes. See, the stirrups are like those little pieces of equipment when you put your feet when they do the pap smear. Those are stirrups. Or if you have right horses, when you put your feet right there on the horse, on that stuff, I don't even know how you call. That's basically what's called. the seating, whatever for the horse ride. I ride horses, but I don't recall what's the name of that stuff. I'm not using it much, so totally forgot. So that's basically what it is. So malleus, incus, and stapes. Malleus, also known as hammer, incus, also known as amble, and stapes, also known as stirrup. I haven't seen these questions prior on exams, but I'm pretty sure that they're going to ask you about these small bones inside the ear. Remember, they are called the ossicles. So what are ossicles? The smallest bones, the tiny bone inside the ear. They are bones. And they receive the name according to their shape. Malleus, incus, and stapes. Malleus looks like a hammer. You know what's a hammer? The incus looks like an embolt. You don't know which one is it, but it is a tool that they use, farmers use, kind of, plant some seeds, something like that on the soil. The stirrup, that's a lot easier. So they look just like that. Now, what is the function of these little bones? Just like the tympanic membrane, they are going to pass the sounds from the external ear through the tympanic membrane to the inner ear. So the middle ear is like a bridge, and you're gonna have these little bones right here. Fortunately, we can see these little bones inside. Let me see if I can do this larger and give a little more shape to this, but still, I don't know if you can see them a little better. I'm making it very large. So right here we have the hammer is right here. It is connected right here to the tympanic membrane. Is the first little bone. See, it looks like this. It's a hammer. So it's connected right here. So when the sounds comes right here through the ear, hit the tympanic membrane, because the tympanic membrane's membrane, it vibrates and it touches this bone that is right next to it. So it hits this bone, the hammer, and the hammer hits the incus, which is this one, and the incus hits the stirrups, which is this one right here. They are not fused together. They are separated. These little bones are not fused together. They are close to each other. So when the tympanic membrane hits this bone moves and hits the other one. This is like the domino effect. You know what is the domino effect, right? One domino right here, one domino. And if I push this kind of push the other one, and all of them goes flat. So that is what's happening right here. So the sounds pass through these little bones, and right here the incus, the stirrups are connected to another membrane, not connected. It hits another membrane, just like the tympanic membrane right here, and it vibrates and it hits this membrane, and the sounds passes through all these structures right here that we're going to talk about later on in the inner ear. And then they go to the nervous system, to the brain. And the brain is going to interpret the sound. Oh, I heard the professor saying the ear canal, the wax, the little ossicles, the tiny bones. Oh, I'm getting an understanding now. So the brain is the one that's going to interpret those sounds, those wave sounds that enters from the outside. And it is in a matter of seconds. Because as I'm opening my mouth and letting words out to my mouth, you immediately hear about them. And you start translating it immediately. Not you, your brain. And it does it in a matter of seconds. See, when you hear a sound, let's say a car horning, you hear it. If it is an ambulance, you recognize it. If it is the police, you recognize them. If it is music, you recognize them. If it is noise, you recognize them. Somebody screaming, asking for help, you recognize that this person is not singing, this person is not happy. No, somebody's crying, you recognize that. The sounds of water dripping, like when you have a lake. So all those things comes together because of these sound waves that comes through the external ear canal and then hit the eardrum. So all these structures needs to be in good state of health. Because if one structure is damaged, or there is an obstruction here, there is wax right here, these waves cannot pass, or they're gonna have a difficulty going through. So sometimes you kind of hear something, but you don't hear well. Think about somebody's talking to you over the phone. They are in a club, in a discotheque, and lots of music, lots of noise, or in a stadium or somewhere else, making a lot of noise, or the train is passing by. You're not going to be able to understand because there are interference, there are barriers to communication. Well, that can be on the outside, but that can be also in the inside of our ear. We have problems. We're not going to be able to hear something because we have something within the external ear canal. Maybe the tympanic membrane is damaged. Maybe the little bones, the ossicles are damaged. Maybe my nervous system is damaged inside the inner ear, so I'm not going to be able to gather all these stimulus, all these auditory receptors. All these wave sounds are not going to be captured. So that's how this works. Any questions about the middle ear? So what is important about the middle ear, once again, for now, it is that it contains these three little bones. That is it. These three little bones are there. And what is the purpose of these three little bones? Pass these wave sounds from the external ear canal through the tympanic membrane. They're going to pass it to the inner ear. So that is how these actually work. Any questions about the middle ear? We still have another structure that's called the oval window. Remember that I told you that here within the wall of the middle ear that connects with the inner ear, there is another membrane, just like the tympanic membrane. But we're not going to call it tympanic membrane. There's no tympanic membrane 1 and tympanic membrane 2. No. There is only one tympanic membrane or eardrum, which is the one that separates the middle ear from the external ear. That is right here in the middle, in between the middle and the external ear canal. Then we're going to have the oval window, which is going to be the stapes that are going to be connected to the inner ear, another membrane. So the stirrup, which is the last ossicle, this tiny bone that is very close to the oval window, this membrane is gonna, when it vibrates, because sounds are coming in, it vibrates this last little bone and makes this oval window membrane to vibrate. And then passes these sounds through the oval window to these structures inside the middle ear, which we are going to discuss. So that's basically how it works. So let's make this smaller so we can go over this. The oval window, see, there is a window. It has the shape of an oval. That's basically what it is. It's an opening in the wall of the tympanic cavity through which the stapes transfers vibration to the inner ear. So right here we have it. This is the stapes. This is the oval window right here next to it. Let's pull the dot in a different color so you can understand right here. There we go. So let's put that color. Let's put this blue color. Yeah. So right here, there is an oval window right here. So the sounds passes through here to the tympanic membrane, to the hammer, to the incus, to the stapes, and the stapes makes vibrate the oval window, and the oval window send these sounds through all these canals right here. There are a bunch of canals. Then this snail that looks like snail. I'm gonna call it names later on, and then to the brain, to the nervous system. So that's basically what's going on right here. Very interesting, huh? So it's not difficult just to see the trajectory of the wave sounds going through the external ear canal, hitting the tympanic membrane. The tympanic membrane, when it vibrates, makes the first little ossicle, which is the hammer, to vibrate. Then it passes the vibration to the incus, the middle little bone, and then to the stapes, the last bone, the ossicles, these tiny bones inside the middle ear. And when this incus of these stapes is vibrating, makes this oval window membrane to vibrate, and then passes the sounds through all these other canals within the inner ear, and then goes to the brain. So that is exactly what it's telling you right here. And within the inner ear is going to stimulate the hearing receptors within the brain. So that is what's really important from this chapter, because it's very interesting. Well, it's very interesting to me. So that's basically what it is. Now we are going to move to the inner ear. Any questions about the middle ear? Good. Oh, before we get there, there's another structure. This is the middle ear, the auditory tube, which is called the eustachian tube. If you ever took anatomy and physiology prior, you probably remember the eustachian tube. Probably not. This is something that you don't remember if you don't use it, right? But there is a little channel that connects the middle ear with the throat. That's basically what it is. Because remember, the middle ear is right there in the middle. It's encased. How are you going to balance, to reduce pressure inside the middle ear if it wasn't because there is a little opening to remove all these compressed sounds in there? Can you imagine a room without doors, without windows, without anything? Well, it's not a room, right? And this is a structure that we have some very important functions within these three little bones. Now we need to decompress this area. Think about you have a bottle of soda. You shake it. When you open it, all this gas is going to come out because when you have it closed, you didn't notice anything that was inside. So the middle ear is the same, it's closed. And if something gets inside and it is too much, how are you going to get rid of whatever you don't need? You have to have an opening. Well, the middle ear has this opening that is called the auditory tube of the eustachian tube. Eustachian was the last name of the medical doctor of this neurologist that discovered this little tube and gave him his name. He called it after his name. So that's basically what it is. So this is the eustachian tube right here. Oh. See, this is the eustachian tube and it's connected to the throat. So whenever it gets compressed right here, too much air, too much liquids, too much of anything that probably gonna get in here, it's gonna get decompressed, it's gonna be drained to this tube. So that's how it is. So that's called the auditory tube or the eustachian tube. It says right here, connects the middle ear to the throat. Now, possible questions for exam. Remember, the ossicles, the tiny little bones in the middle ear, not necessarily they're going to ask you the names of each one of those little bones, but they will ask you where are those smallest bones of our body located, middle ear or ear. Now, another question that you might have, it will be, which is the structure that connects the middle ear with the throat, or the middle ear with the pharynx? Pharynx and throat is the same. It's just that pharynx is a medical term. The throat is the layman term that we use to talk to people who didn't study medical terminology. So what is the name of this structure that connects the middle ear with the throat? It's called the auditory tube or the eustachian tube. That's how it's called. And what is the purpose of this auditory tube? What's the function? Very important, it helps to maintain equal pressure on both sides of the tympanic membrane and the middle ear. So pressure, remember the sounds enter here. That causes pressure to this membrane vibrates and the sounds right here. But if this compartment is completely closed, some of the information is gonna go here. What about noise? How are you gonna withdraw noise? Noise is like garbage, something that you don't want, you just let it go. Then you decompress it right here. I know for a fact most of you have fly on a plane. What happened to your ears when you fly on a plane? Kind of get full of air and you have problems kind of hearing. So that is the purpose of this tube, decompress all this pressure inside the ear or wherever it is in the ear, decompress it, give this opening, this channel to remove whatever it is inside that is compressing the middle ear. So that basically was talking about. That's the functioning, the physiology of the structures of the middle ear. But for exam standpoint, you need to know that the structure that connects the middle ear to the throat or to the pharynx is called the auditory tube or the eustachian tube. Remember, that's basically what I want you to remember from this particular slide. Any questions about the eustachian tube or the auditory tube? Good. Let's move to the middle ear. The middle ear is very complex. Remember that I told you this is the sensory part. This is the sensory part, meaning it is controlled by directly the nerves of the temporary lobe, the auditory nerves. So fixing this area of the ear, almost impossible. Almost, I said, because science is trying to do many things to trying to fix, to give the opportunity people who were born deaf or who have a trauma, accident, and a loss of hearing, but because it was a damage to the nervous system that controls that part of the brain. But they are still working on. So 3 parts of the inner ear that it's called the 3 labyrinths. So we have the semicircular canals because they look like canals, see? Semicircular canals. Here we have another one that is on the other end, semicircular canals. So the sounds travels, see, this is the oval window. Here are the stirrups from here. So the sounds comes right here, makes this membrane vibrate, send these sounds through inside these tubes, because these are tubes, contain some liquid inside. And the sounds are going to be traveling through that liquid. So these semicircular canals contains something, see, it says some labyrinths, some structures, hollow spaces with some liquids. It is called lymph and travels all the way around here, this like going through a roller coaster, if you will. They're gonna pass right here to this null shape. We're gonna call it names later on. And then it's gonna go through these particular nerves, cranial nerves, to the brain. So I'm explaining you this in a very, very simple layman way, because I'm not going to use too many medical terms. I'm going to mention them, but then I'm going to give you some layman terms that we know these structures as. Remember, semicircular, this is just canals, contains some liquid inside, and all these sound vibrations are going to pass through it, because this is the sensory part. This is the nervous system now. Very complex. If something happens right here, so these sound vibrations that comes right here to the oval window, to the middle ear, that's as long as they can go. They do not pass anywhere else. So they are not going to be connected to the brain. So the brain is not going to interpret what's going on. That's what happened to deaf people. The sound enters the external ear. The tympanic membrane is normal, not a problem. The little ossicles, they are normal. They receive all these vibrations, pass it to the middle ear. But when it just comes to the middle ear, that's it. They die right there because the nerves that are connected to the inner ear are not functioning. The brain nerves, these nerves that connects with the ear, they are not functioning. They are damaged. So this is like you going to the school or to your workplace and you got stuck in the middle of nowhere. The train is not moving anymore. That's it. You're not going to be able to reach workplace. You're not going to be able to reach the destination. That's it. Everything else was fine until I got to this point, that from this point on, unable to move. So you got stuck right there. So the sounds are going to get stuck right there in the middle. You're not reaching your words, so you're going to be absent You're not gonna get paid, probably you're gonna get fired. Well, the person is not gonna hear anything. So you can be talking and talking and talking, oof, like talking to the wall. Because they're not gonna be able to hear you. They might be looking at you like, what is this person saying to me? I'm lost. That's why we have sign language, because I can do all these movements, my hands and everything else. And the patient can, if they can see, they have a good sight, then they can interpret those. But if I don't know sign language, we lost right there too. You cannot convey your information. So those are the semicircular canals. All these right here. Then you have the vestibule. Vestibule is right here. Now, this is the part of this structure that connects these canals, all these canals, with this other snail shape, which is this. This part is the vestibule. These semicircular canals are connected to this snail shape through another structure. Well, that structure is called the vestibule. That's it. It says right there, very simple, the vestibule connects the semicircular canals with the cochlea. The cochlea. The cochlea is this snail shape right here. Right here in this area. That's the cochlea. So these are just canals. Still, we have not reached the auditory nerves. So we are going to have all these nerves picking up the information from the cochlea and bringing them to the temporal lobe when we have all these auditory receptors of sound. That's basically what it is. Now, it says right here, the cochlea is a bony structure shaped like a snail and filled with two fluids, perilymph and endolymph. Do not worry about that. Just know that inside these canals, we're going to have some fluids. And through that fluid, the sound are going to be passing through until they reach the nerves of the brain and reaches the part of the brain that translates all this information. Think about the phone system. You're calling someone from here to someone else somewhere else. And it goes through all these particular spaces, dead spaces, because we don't know where you are. Even though if I know where you are, still, I'm not seeing you, so I'm connecting with you. But if you have no signal, I can be trying to call you 100 times. I do have a signal. I did pay my bills, but you do not have a signal over there. So if you don't have a signal, it doesn't matter how many times I try to reach you, how many times I dial your number, still, you're not going to be able to pick up because you don't have signal. That is exactly what happened right here. There is no signal if the person is deaf. So here is where it goes to the nerves. This is like Wi-Fi. You can have a phone, but if you don't have a Wi-Fi, probably it doesn't work. If you don't pay for your service, you're not connected to any network. It doesn't matter if you have a phone. Think about you have an ear, but the ear is not working. It's like having a phone that is damaged or it's not connected to any network. Good for nothing. You just have there as a decoration. So that's exactly what's going on with these systems. So I'm giving you samples, real scenario, samples, you can understand how this works and how these structures are so important for us so we can have a normal life. If one of the structures is not functioning properly, well, we're not going to be able to use it much, or maybe not to use it at all. Now, within the cochlea, because it's one of the most distal structures of the inner ear, because now this is going to be connected to the nerves from the ear, the auditory nerves. So now they're going to go to the brain. But here we have a structure within this nerve structure or lookalike structure that is going to be called the organ of Corti. See? The organ of Corti is inside the cochlea. Right here inside the cochlea, there is an organ right there, which is actually the one that have the receptors of hearing. And from here, it's going to go to the nerves, the auditory nerves, to the brain once again. So this organ of Corti, see, Corti was the name, the last name of the medical doctor that discovered this structure. That is the one that captured all these wave sounds that came from the outside to the external ear canal through the tympanic membrane or eardrum, passes to the middle ear, through the malleus, the incus, and the stapes, and then hit the oval window, enter to these semicircular canals through these lymph, in general, this liquid. Then they pass it through the vestibule, they go to the cochlea, and then inside the cochlea is when you're gonna find like the little brain right there of hearing, which is called the organ of Corti. Remember, Corti was the medical doctor. This was a neurologist, a scientist, who discovered this little structure, and he gave it his name, put his name on it. Well, I would do the same. So he can be remembered forever for what he did. So that was basically what it is. Now, remember that at the beginning, I told you that the ear is not the organ of hearing. It is just an understatement, if you will. So organ of hearing is exactly the organ of Corti, because this is the one that actually picks up all these wave sounds and translate it into something that means something. But it's not going to be revealed until it goes to the temporal brain, the temporal side of the brain, where it's going to be translated and print out. And it says, oh, this guy is saying this. Oh, this sounds, I recognize it. I know what it is. So that's basically what's going on right here. So within the cochlea, we're going to find actually the organ of hearing, which is the organ of Corti. That's basically what it is. We just, in general, always says, oh, the ears are the organs of hearing. Well, in a way, this is just like the capsule that encages all these little structures within. But talking in real terms about all the structures within the ear, this is the actually organ of hearing. That's what it's called. The organ of hearing is not the cochlea, is the organ of Corti. And where is the organ of Corti located? Within the cochlea. That's how it works. Any questions about the middle ear? Remember, semicircular canals, the vestibule, and the cochlea. This is the sensory part. So if you ever have a question on an exam says, which of the following parts of the ear is considered the sensory part? Then you said the cochlea. That's it, because it's the one that actually it is it functions through the nervous system. The other parts are not. They are mechanical. They are not sensory. Okay. So let's move to the sense of sight. Now, the sense of sight, once again, is the eye, right? We're going to talk about those visual receptors. And we're going to see in which part of the eye are we going to find them. But before we get to that latest part of this structure, this special sense, we're going to talk about these accessory structures that are working alongside with the eye, which is not the eye per se. So these accessory organs, we know them. So you probably haven't heard directly this, but some of them, you definitely know this. Eyelids. We know the eyelids. How can we not know them? The eyelashes. So eyelids works as a protective mechanism. Remember, we close our eyes, so no particles are gonna come inside our eyes. Same the eyelashes. When we have our eyes open, the eyelashes are kind of attract and collect all this dust, pollen, whatever stuff, sometimes a little flies coming. And as soon as we blink something like that alongside with the eyelids and the eyelashes, we prevent these environmental particles or insects to come inside our eye. So they act as a barriers of protection. So that's basically, well, it's not the only basics, but in this case are very, very important functions of these structures. Now, I have these seasonal allergies. I developed those seasonal allergies here because in my country, I didn't have no seasons. There is summer all the time. So here with the time changes, the grass, the pollen, all those things sticks on my eyelashes and I rub my eyes and they go inside my eyes. Now my eyes start itching. Not to mention those things that goes through my nose, those chemical receptors that picks up all these environmental fumes or pollen that goes inside my nose with the air, remember? When I'm breathing in. So that made me sneeze, made me cough, caused my eyes to tear. So what you have to do when this happens, when I have these allergies, I have to be watching my face all the time if I go out. If I go out, as soon as I get to a place, I wash my face. So I can remove all these pollen, dandruff, anything, or dander, or from cats, pets, whatever the case may be. Because these are very small particles. And if I don't do that, they're going to go inside my eyes, because usually I roll my eyes because my eyes start itching. But there are good protection barriers for us. Remember that I said when these particles enter my eyes, I start tearing, well, lacrimal apparatus. Well, you don't know about the lacrimal apparatus. Lacrimal means tears. So these are glands that produce tears. Lacrimal is a Latin word, comes from lagrima. Any one of you speak Spanish or heard about something, somebody that is crying, is tearing down. Well, that is this particular glands located very close to the eyes, not very close, within these eye sockets. They produce tears, and tears are a way of protecting your eye. It keeps your eye moisture. And when something goes inside your eye, it washes them away. Because when something goes inside your eye, you start tearing more often. Remember, I told you if some pollen, some stuff enter my eye, or a little mosquito, my eyes start tearing more because these glands get activated because it's a way of protecting your eye. That's basically what it is. So tears not only keep your eyes moisture, but also it protects them. It wipes away with the tears things that enters your eye. Like when I go and kind of throw water inside my eyes to remove stuff from there because I want to expedite, the removal of whatever particles enter my eye. Then we're going to have some muscles that are called the extrinsic eye muscles. These are the muscles that attaches to the eye and makes the eye to move. They make your eye to look longer, to look rounded, to move your eye to the right, to the left, up, down. Extrinsic eye muscles. What they call extrinsic. X means they are outside the eye. They are connecting the eye. We're going to see the eye later on, and we're going to be able to show you these muscles. But this is like having your eye this way, and you have these muscles right here attached to the sockets of your eye. And they are the ones that causes movement to your eye. These are the extrinsic. Intrinsic will be inside, but they are not inside. They are outside, trying to control it. That's basically what it is. Okay, so we know these accessory parts of the eye. Then we're going to move to see these the parts of the eye itself. So that will be here. Structures of the eye. So before we move to that, let's take a break because it's been lots of information that I'm giving you. And I don't want to start up here and say, oh, this is one part. And then you go on break and then I have to go back and explain again because during the break, we kind of forget about it. So what we're going to do is we're going to take a break. We're going to take 25 minutes. So what time is it right now? Okay, let's say that is 7. We're going to come back 7:25. Do that sounds good to you? 7:25?
Okay.
Good. See you then 7:25, guys. Enjoy your break, and I'm going to enjoy mine. See you then. Okay, so we are back. I hope you guys enjoy your break as much as I did. Okay, so let's continue with this interesting chapter, the senses. Okay. So do I have you guys back already?
Yes, I'm here.
Okay, good. Okay, so let's talk about the structures of the eye. Remember, the eye is a special organ because it's large, we can see it. It is located in certain areas of the body, it's not everywhere. So let's talk about the three layers or walls of the eyes. So an eye has three layers or three walls. Let's talk about the outer, the middle, and the inner layer. Just like we did with the ear, we have an external, a middle, and an internal ear, part of the ear. So here we're gonna have an outer, a middle, and an inner layer or wall. The outer layer is called the sclera. The sclera. That's all I want you to know. And for exam, for the purpose of the exam, the outer layer of the eye that is called the sclera is also known as the white part of the eye. I believe that I have it in the next slide, I believe. So whenever you see a question, because these are questions for exam, the outer layer of the eye is called the sclera. The sclera is also known as the white part of the eye. What is the white part of the eye? The sclera. Remember, they like to play around with the same name, kind of phrase it, paraphrase it, play around with these names. The middle layer. The middle layer is called the choroid. The choroid. This is where all the the blood vessels are located. Forget about tunica, forget about fibrous or something like that. Done. Just know outer layer, the sclera, also known as the white part of the eye. That's it. The middle layer, the choroid. This is where all the blood vessels are located. So all the little blood vessels, we're gonna find it in this place. The inner layer is called the retina. The retina. This is the nervous part of the eye. This is the sensory part. Remember the ear, we have the outer, the middle. They are not the nervous system part. The inner ear it is. Same here, because it has these receptors of sight. The receptors of vision are located here. Very similar of how we describe the ear. Certain structures do certain functions, but the inner part of the ear, it is sensory. It is the nervous system. It is connected directly to the temporal lobe of the brain, which have the auditory nerves. The inner ear, which contains the nervous system, the ear nerves, let's put it this way for now, and it is connected with the occipital lobe of the brain because it's the part of the brain that controls sight, the occipital part. So that's basically what it is. We're going to see all these nerves, the optic nerves, and all those nerves that act to control sight. So let's see which ones are. So we have here, now let me do this blue. So this blue is the outer part of the, oh my bad, This is not how it works. This is the cornea. So the cornea in front of the eye, this is the white part. The entire part, the outside, this is called the sclera. In the front, we don't have a sclera because we have a window. Remember, that's where the light passes through. So this part should not be covered because no light will come out through. So we have here inside the pupil, the iris, and right here on the outside, we have this window, which is the cornea, which we're going to discuss later on. So for now, just the layers, the outer layer, which is the sclera, the middle layer, which is the choroid, and the inner layer, which is called the retina. They like to ask about the outer and the inner, because the outer, we can see it. The inner is the one that kind of produce all these functions. It makes all these important functions of our eye, which is produce this image and identify the image, translate the image. What is it that we're seeing? Are we seeing a car? Or we seeing a building? We seeing another person? We seeing, I don't know, a TV? We seeing a table? What is it that we're seeing? What is the image that we're seeing? So that is the retina, the inner part. Remember the ear, the inner part within the cochlea. That's when we have the nerves, the organocorti, the nerves that goes to the temporal lobe. That is what translates what we can hear. That's when we know what is it. Is it someone singing? Is it the person that we like to hear the songs? Is this our favorite singer, our favorite song? It is a sad song. It is a happy song. What is it? Is somebody screaming? Is somebody calling our name? Is somebody giving a lecture like me? What is it that they're talking about? That is the hearing. And the vision is you can see me over there through the camera. I can see you guys through the camera, even though if you have it off, I just imagine that I have you there. But if I have the chance to see you, I'm going to be able to see you. So I know and identify each one of you because I've met you before. It says, oh, this is this one, this other student, and so on and so forth. So that's how we recognize things. Because we see them, we create images. We're going to talk about how we create images, just the way that we did with the sounds. Through where the sound enters, to where the light is going to enter, because this is going to be the light that is going to enter the eye and produce an image inside the inner ear. But for now, talking about these walls right here. So the outer layer is called the sclera. This is the middle layer right here. So just the middle layer. Well, I'm not perfect, so I'm just putting 3 layers, one on top of the other. And the inner one, let's put it green. This is the inner layer. So there are 3 walls. There are 3 walls, and they just come right here. So that's basically what it is. Just know basics. Sclera, the choroid they never ask. Sclera and the retina, these are not the most important parts of the eye, but these are the parts that you will encounter some questions on your exam. Remember, they're going to ask you what is the inner layer of the eye, the retina. What is the sensory or nervous part of the eye, the retina. What is the image produced, retina. If you don't see, what is the problem? The retina most of the time, if it is sensory. But we will go over that. So that will be the inner, and the outer is because this white part of the eye that surrounds the iris, which is the color of the eye, that will be also asked. So we're going to go over in details from that. So the outer layer is right here. I'm gonna call it right here. Is the outer, the sclera. Then we have the cornea plus the sclera. This will be the area, the outer layers. The cornea is the transparent part. This is what we call the window of the eye. I just mentioned it. It's not the lenses. Be careful, the lenses are interior. I'm not talking about this. I'm talking about this right here. This is the window. It is transparent, it's the cornea. It's this shiny stuff that you see in the front of your eye. If the sclera will be covering all that, you wouldn't be able to see it because the sclera is made of all these fibers, very strong fibers. Remember, every organ, the outer layer is very strong. Why? Because you got to protect the interior part. So that's basically what is going on. See right here, the sclera, the white part of the eye. This is the one that gives the shape to the eye. See, gives the shape, the sclera. And it protects the content inside the eye. Everything that is inside this is fluid. Here we have some organs that we're going to talk about later on. Here we have the lenses. Here we have more fluid. Here we have the cornea, the pupil. Here we have this space where the light passes through all the way down. So that's basically what it is. But we are going to talk about just these major structures. We're not going to go into details, specifics. We're not going to get too technical. So basically, that's what I want you to know, the eye. So the sclera is the outer part, once again, and it's the white part of the eye. So if they ask you, because usually this is the type of question that you will get. This is known as the white part of the eye. Which one is it? So they give you the options. So sclera will be the answer. This is the window of the eye. Immediately, you're going to be looking for the cornea. Remember, I'm giving you all these hints because usually, you know, when you see an exam, you think that the questions are going to be straightforward. Unfortunately, not all of the questions are going to be straightforward. So we need to know little tricks here and there so we can answer and pick the right answer for your exam. When you start working, things like that, well, usually this is not going to be asked. So that's basically what I want you to know. So the outer layer is called the sclera, which is the white part. Just think about these when you open your eye and you look yourself in the mirror on your camera, you're going to see the white part of your eye. That is called the sclera. And that little portion in front of your eye that you can see surrounding the white part, which is the color of the eye, that area, that shiny area, looks like a window. That is the cornea. That's on the outside. It just resembles a window. So write it down or just mark there something so you can remember when you review your notes. Okay, moving on. The middle, the choroid. So here you're not going to worry too much about something that they're going to ask. Just remember that the middle part, which is the vascular part, because it has the blood vessels, that probably will be something that it will be asked, but it is not often a question that you will get. The choroid provides blood supply, contains melanocytes. Now, this is important, just like the skin. Remember, the melanocytes are the ones that gives the color to the eye, to the iris. The more melanocytes, the darker your eyes are going to be. If you have like dark eyes, then you have lots of melanocytes. If you don't have many melanocytes, then you have lighter eyes, like blue, green, hazel, and then gets a little more darker. So that's basically what it is. So the choroid, we're going to have not only the blood vessels, but melanocytes, because once again, it gives the color to the iris, because the iris is the color of the eye. We will discuss that. Also, it has some muscles there. Remember, ciliary muscle, because these are the muscles that holds the eye in place. Some ciliary muscles, some lateral muscles, a bunch of muscles right here that holds this part right here. And this will be the muscles that I told you. The extrinsic muscles are these ones on the outside that makes move your eyelids, your eyelashes, close your eyes, open your eyes, move your eyes up, down. That would be on the outside. But in the inside, we have these ciliary body muscle. These are the ones that attach to the lenses and make the lenses elongated or they shorten them. Depends on what we see. When we look something far distance, we open our eyes very big. This is like when you're scared, when something scares you, your eyelids pulls up and your eyes looks larger. Once again, if you're scared, your eyes kind of pops up or out, and then it becomes kind of rounded. But when you're looking at long distance, then they become elongated, because this is how it works with these ciliary muscles. Now, you're not going to be asked that, but once again, the ciliary body changes lens shape for focusing short or long distance. So these lenses becomes elongated or can become rounded or elongated. It pulls the lenses to stretch them and then they shorten them. That's what these muscles do, these ciliary bodies. No worries, they don't usually ask about that, but know that there are some structures within the eye that moves whatever is inside. Remember, it has to have some type of muscle structures that, changes the shape of the eye inside depending or what is it that we are focusing on. So that's basically how it works. Now the iris. Now the iris is important because they like to ask this. The color of the eye is called the iris. The iris is also known as the color of the eye. That's it. Now, what is the function of the iris? Remember, the iris is a muscle. It says right here, it's a pigmented muscle, meaning pigmented means that it has color. Pigmentation has color because we have different type of colors. Depends of how many melanocytes do we have in the ciliary or the middle ear, no, middle ear, the middle eye. So that's basically what it is. So the iris is the one that gives the color. Within the iris, you can see that there is a little opening. We're going to see an eye later on. This is an eye. Oops, this eye is really freaking me out. There is a little opening right there. That's called the pupil. But this iris right here, the color of the eye, stretches and contracts. Stretch means it becomes elongated, contracts, comes back to the normal size. So when they do that, this little opening right here, it becomes larger or it becomes smaller. See, during the daytime, our eyes are kind of certain size. The pupil are certain size. At night, it changes. because at night we don't have enough light, so we try to open up our eyes even more, so more light kind of enters through this pupil, because if it kind of closes, we're not going to see much. During the daytime, they closes a little more. They leave a very space. Have you noticed, have you experienced, that's the right word, have you experienced that when the sun is shining and it's very hot, you cannot look at the sun directly or to the lights directly because your eyes tend to shut down. You want to close your eyes because it's too much. It's like somebody flashing a light on you. You go like, oh, wait a minute. You kind of close your eyes, not to mention that you close your eyelids because it is too much light going through it. So the iris is the one that controls the amount of light that passes through the pupil right here, because it's the little hole opening within the iris. This is the iris. This is the iris. It has a little hole right here where the light passes through. Without that opening, without that window, the cornea on the outside of our body, on the front of our body, we wouldn't be able to pass no light. So then we wouldn't be able to see or to notice anything. You know, at night that you can barely see. If it is very dark, you're not going to be able to see at all. So that's the reason why. Because it's dark, we need light in order for us to see something and identify whatever we see. So once again, the iris is also known as the color of the eye. The iris is a muscle. That's what it says. It's a pigmented muscle. That's what it's called, the color of the eye. Because it contains the pupil within. In the center of the iris, you see a little dot that is black. It doesn't matter what color your eyes are. But this little opening, this circle in between the iris is going to be dark because it's a hollow space that goes all the way inside your eye. So you can see through. So the light passes through this little hole all the way to the back, because back here is when we are going to have some structures that we're going to call it later on, where we're going to have these sight receptors, visual receptors, or vision receptors, whatever you want to call. So that is basically what it is. Very, very interesting. It is small structure, but it has very, very important function, which is sight, vision. You know how important it is for us to see something? Any questions about the middle or vascular layer of the heart? Tunica means layer, means wall. Tunica is like a wall. Tunica is like a dress, just protect something on the outside. The pupil. The pupil is very important. Now you can see here three diagrams of an eye. And I'm going to tell you what happened with light. I already explained it to you, but it's a good thing that you see the eye, how it functions. The pupil is a window or opening in the center of the iris. I already mentioned that. So the pupil is this one. This is the pupil. The one on the outside, this is the iris. All these brown color is the iris, and here is the pupil. So depends of the amount of light that we are exposed to it, our pupil changes size. which means it dilates, meaning it becomes wider, or constricts, which means it becomes very narrow. So when we have bright light, think about it dilates. So we are seeing things, so we have our eyes completely open and we see all the things, and all the light passes through the back of the retina to meet the receptors for vision. And now we're going to be able to interpret what is it that we're seeing. It said it constricts with dim light. So when there's no light, well, we don't need to see much, right? So that's basically what it is. I think that this is not right. It is the other way around. I'm pretty sure. It constricts with bright light and dilates with dim light. Remember what I told you? That if someone is on the daylight, you cannot look at the sun directly. It's shiny and you look, oh, no, that's what we need sunglasses. Because you can barely see because your pupils constrict. So this is the other way around. I mentioned it before, it was right, but now that I'm reading it, I see this, something happened. Somebody came here and, kind of played tricks on my lectures to make me look bad. I think that's what happened. Let's cut this and let's put it right here. And paste, dilates, and pupils. What was that before? Constricts with and dilates, and here is dims with bright light. Oh my gosh, I just forgot what I was doing here. Oh, dim light. Oh, bright and dim. Oh, what I changed was different. Bright and dim. So dim right here. And bright right here. That's what I tried to do. Yeah. What I do, I did again the same. No, I copied the wrong thing, guys. The pupils constricts. Oh my God, that's what I was trying. Constrict. Constrict. With a bright light, dim light. No, it's bright. Now I'm gonna put bright. I was making mistakes right here. Okay, and now constricts and dilates with dim light. That's how it works. Now it is correct. Corrected over there. So pupil constricts with bright light. Remember, we wear glasses because if the sun goes directly into your eyes, you're not gonna be able to see. So that's why they constrict, because light cannot go through. And dilates with dim light. So when it's dark, your eyes try to open more so you can have more light coming in because it's too dark. So that is how it works. That is it. See? Normal light, bright light. Yeah. So here it is. The picture shows that. So look at this pupil on the first picture here versus here. See here, if it is bright light, see, normal light will be this one, normal. This is the pupil. This is dim light. See how big it is? And here is with bright light. It constricts. See? So it was just something wrong with the information there, but I was writing the explanations when I was reading and I was like, oh, wait a minute. It doesn't make no sense. So yeah, we have a normal one. It is like 5 millimeters diameter. And when it becomes, once again, dark, the darker it gets, the pupils opens more because you want more light to go through. But if it is too much light, then they constrict, they become very narrow. So don't want let the light passes through because it's too much light. Okay. Any questions about the pupil? Remember, the pupil is the little opening in the middle of the iris. The iris is the color of the eye. It's a muscle. This muscle stretches and contracts depending of the amount of light. So it controls the amount of light that enters the eye. So whenever you hear a question, which structure of the eye controls the amount of light that enters the eye? That would be the iris. And through which structure does the light passes through? Oh, that would be the pupil. But sometimes certain tests, don't get me wrong, they tell you which controls the amount of light that passes through, and they say the pupil. Well, if you don't see the iris, you see the pupil, pick the pupil. But once again, it's not the right way to ask a question. So that's basically what it is. Any questions about the iris? Remember, the color of the eye is muscle. This muscle constricts, this muscle stretches and contracts, depends of the amount of light that passes through. So, and the pupil is the structure that allows the light to pass through. But the iris regulates how much light passes through this pupil because it's the one in charge of constricting or dilating. If you have gone through your ophthalmologist, the specialist of the eye, they put some drops sometimes if you have problems with your eyes, and they start examining your eye. Why did they put those drops? Because those drops are to dilate your pupil. Because we have these lines right next to us, and we cannot kind of how can I explain this? It's very difficult for you to keep your eyes open when a light is right on top of you, it's shining right on top of you. So we put those drops, those called mediatrix. Those not gonna be us, but these drops that we put there is to make your your pupil to be very big. So when we look through the lenses in your eye, we're gonna be able to see all the way on the back of the retina. That's basically what it is. Later on, after you finish this procedure, you're not gonna be able to see. Sometimes you have to bring someone to get you home, or you have to stay in the office for a couple of hours until these drops effects subsides. So probably someone of you went to the doctor and they did this procedure. So that's basically what it is. So it is important to know this. Let's talk about the anterior portion of the eye. So once again, we're talking about every single structure. So the anterior cavity. So we have an anterior cavity and a posterior cavity. So the anterior cavity is called the aqueous humor. So pay attention to these names, aqueous humor. Aqueous means water. Humor is just the name that they gave to this structure because this is not actually water. It is liquid, but it's very, very clear. So that's basically what it is. Now, if you notice, this is the cornea. All these round dome shape right here. This is the cornea. So here it is. This is the window of the eye. This is the anterior chamber. Right here, this space is filled of fluid. Right here, I'm going to put fluid. So all this is the anterior chamber. And this gives shape to the eye in the front. And this liquid, it is produced by some structures right here within the eye. Remember the lacrimal hides and some other tubes. So here we have a little tubes that drains this liquid. When you have too much liquid right here, it drains these. It has little tiny tubes there. Later on, we're going to talk about a condition that is called glaucoma, which is when this liquid increases too much. You have too much liquid right here because these little tubes, the drainage right here, they are stuck. They are clogged. They are blocked. So this starts increasing and increases pressure in the cornea and the structures below. And then you develop pain in your eye, and then you're not going to be able to see. So that, we're going to talk about conditions later on. But for now, this is the anterior chamber. Once again, it's part that I put right here. As this is the anterior chamber. The one that I put right here, let me remove all this. The one that is in blue, and it contains this liquid that is called, or fluid, that is called the aqueous humor because it's liquid. That's it. Now, it's very important to have this liquid because the light is going to go through this liquid and to hit the lenses right here in the middle. See, this is the pupil. The light goes right through this, hit the lenses, which are this one right here, and the light goes all the way on the back when we have these receptors of vision. Later on, we will discuss what receptors are those. So that's basically what it is. So we have the lens. So the lens are a transparent structures. It says biconvex. Well, they can change their shape, see? Changes shapes for long distance and close vision. So these lenses right here, when we see something that it is far away, they become long, elongated. So let's say that these lenses are like this. When you see something far away, then they become like this. And when it's something that is close, they become back to normal or become even smaller because they refracting means that they change shapes. Refraction. So that's basically what it is. So we have these structures, the lens, the anterior chamber or cavity, which is called the humerus of the aqueous humor. So that's basically what it is. We have a lot of more structures right there, but we're not gonna go into details because it will be too much. So just gonna leave it there. Any questions about the anterior portion of the eye and the lens? Remember, these lenses are the ones that becomes foggy. They become opaque. So they become like the foggy windshield of your car when it's raining and you can barely see through. That's what the person we call it cataracts. That's problem with the lens. Problems with the anterior cavity or the aqueous humor is the condition that we call glaucoma. Remember, increase liquid or this fluid in the anterior cavity. And it causes eye pressure. And because it causes an eye pressure, it's like your eye is going to blow. And it causes very bad pain of your eye and your head. And if it's not treated, you lose your eye. So once again, these are the structures. The inner layer. Remember, we're talking about all the layers that you go through. The inner layer, which is the retina. Right here it is, the retina, contains visual receptors. Those are called photoreceptors. That's what photography or photographs or photography comes from. Because these cameras to take pictures, to record videos, they have all these receptors to capture images, just like the retina or our eye. So that's basically what it is. So the retina is the sensory part of our eye. It's the inner part. Very, very important. Because if this inner part is not functioning, then we can actually lose our vision, whether partially or completely, we can go blind. This is the part of the eyes of the person who is blind that is damaged. Not to mention the occipital part of the brain that controls vision is also it's also damaged. Or doesn't have contact, no connection. Remember, think about the cellular phone. You're talking, you lose signal. The other person, it doesn't matter, has a phone, but it's completely dead. It's like running out of battery, not having a signal. Same goes for your eyes. You're doing a video call, like we're doing here now. If something happens within the camera, you're not gonna be able to see me. Or you shut down the camera, right? I'm not gonna be able to see you. So that's basically what it is. So the retina does the same function as the cameras, the photographs that we take are, based on the retina, these receptors. So if you see the eye, it has a bunch of blood vessels. Remember, when you see red, that means arteries. When you see blue, they are veins. And of course, here we're gonna have capillaries, little, arterioles, venules. Right here on the back of the eye, we have this little part right here, this circle. That's with the nerves, all the nerves for the eye enters and leaves and it goes to the brain. So that's basically what it is. Here in this part, we have another structure in the back of the retina. That is all the way on the back. We've seen the eye from the back portion. Here we have another structure that is called the macula. And here within the macula, we're going to have something that is another little structures, the fovea centralis, when we have all the receptors. When we have receptors for black and white and color. Because remember, at night, we see things black and white. During the daytime or light, we see things color. Turn your lights off in your apartment, and you're gonna see everything black and white. You see kind of shadows, right? But if it is in the daytime, I can see every single color, every single part of my apartment. I can see everything because I have a bunch of stuff here on my desk. So if I look around, I see every single color. But at night, I don't see it the same way. So remember back in the days, well, some of you probably still have seen some pictures, black and white, movies that were black and white. Remember? Now everything is color. So back in the days, well, they didn't have these receptors for color. But based on the receptors of the eye, finally technology catch up with the functions of the eye. And now we have everything in color. Now, seeing something black and white is very, very rare, unless, you've seen watching an old movie or someone who want to do it just as a reminiscence of how it was before. Other than that, everything is just colors. So that's basically what it is. So we're going to talk about these macula and the fovea centralis. And of course, the optic nerve, which starts right here in the center, all the way on the back. So when we look at the eye through the pupils, we look at all these structures. So we shine a light from here, and we enter right here to see this part, all the blood vessels. We see everything that is going on the back of the eye from here, from this part. So we're seeing all the way on the back of the eye. So that is basically what it is. So we'll talk about this macula and the fovea centralis in a little bit. So the retina, what I want you to know about the retina is that it's the inner layer, and it's the one that contains these visual receptors that are called photoreceptors. Because every single time that we see something, we're creating an image. And those many images are called photographs. So that's basically what it is. Any questions about the inner layer of the eye? Remember, this is the sensory of the nervous part of the eye, just like the inner ear. The posterior cavity. So now we are focusing on all that red part. So the back of the eye, which is this is the retina right here in the inner part, So everything that you see inside this blue part is called the posterior cavity. The posterior cavity is also known as it's not also known, it contains this fluid, but this is not a liquid fluid. This is a thick gel-like substance or fluid, like jelly. That's the one that gives the shape to the eye. Think a little balloon filled of water or air. But in order to keep more consistency and to have certain things kind of flowing inside or navigating inside or suspended inside, it has to be kind of thick. Other than that, if it is just water, think about something that is solid goes all the way to the bottom, right? No, here it's going to be suspended everywhere. Like jelly, think about that. You don't separate the liquids from the solids from jelly. It stays there. The whole structure, it is condensed, looks like that. So it's called the vitreous humor. This viscous, thick, jelly-like or gel-like structure of substance, which is all the red part inside these blue lines that I draw inside the eye. So if you ever have a question that says, okay, what is the posterior part of the eye made of? What contains? Vitreous humor. What about the anterior part? Aqueous humor. Aqueous comes from aqua, water. So that's basically what this is all about. Just that. Not gonna go into any details. Now remember, the retina is the one that forms the walls, the inner walls of the eye. But here we have the lenses that separates, and the ciliary bodies, muscles, hold the lenses, and this liquid doesn't move to the front part, which is the anterior cavity, which is here. No, it is separate. So the anterior cavity right here, it separates the posterior by the lenses. So the lenses separates the anterior from the posterior cavities. So it is important to understand that, because who knows, might be question for exam. Any questions about the posterior cavity of the eye or any parts of the eye that we have already covered? Okay, moving on. Let's talk about these photoreceptors. Very, very interesting. Photoreceptors are modified neurons of the retina that sense light. No worries about that. No one in this program will ever ask these questions like that. It's a modified neuron, blah, blah, no. What you need to know, the photoreceptors are those receptors that captures light and then they make an image. That's it. Remember, when light goes through the cornea, through the anterior chamber, through the aqueous humor, if we will, through the lenses, or through the pupil, through the lenses, through the aqueous humor, to the vitreous humor, then go all the way to the macula. The macula, and then you have there the fovea. So those two structures are the ones that are going to contain these rods and cones. Because color, think about this, think about the cues that I'm giving you. Cones, CO, think about color. Provides vision in bright light. So this one produces color vision. See, the cones, color vision. Color, cones, color. The rods, don't worry about that because it's not close, produce colorless. Colorless, not one of the terms that you're going to be used. It's going to say black and white. Black and white vision. That's basically what it is. With something is, you can see something dark, something like a shadow. Think at night. So tonight, you're going to turn your lights off. But now you're going to consciously think about it. Says, okay, I'm going to turn the lights off and I'm going to look around. It's very dark, no light coming from anywhere. And then your pupils are going to get very big. And then you're going to start looking around and everything looks like black and white. That's it. You're just going to see shadows there, but you're not going to distinguish things. So these photoreceptors have two different shapes, rods like cylinders, cones, just like a cone. Little cone right here, like this. So that's how they look like. So rods, black and white vision, cones, color vision. Remember, don't forget cones, color. If you know that, you know when they give you rods, then I don't think they're gonna tell you this. Just in case, at least you know, you heard about it. They said, oh, I remember now. So you don't have to be kind of wandering around, oh, wondering about, oh, wait a minute. What do you mean photoreceptors? That professor never mentioned this. Oh, some of you still gonna say that I never mentioned it anyways, because you hate me, because you wanna make me look bad. Just kidding. Okay, so that's basically what it is. So the photoreceptors are rods and cones. The rods are black and white vision. The cones are color vision. That's basically what it is. So during the light, when we have in front of the light, it is lit outside, you see colors. When at night, no light, rods are the ones that start functioning there. So here we have them, the rods and the cones. You see right here. So, well, these are the real ones. So if you see here, they are more like cylinder versus the drawings that they have over there. And the other one looks like they're actually cones. See? See? So that's how we see. Said right here, the rods and the cones are named for shape of receptive ends, for the shape that they have. So the rods are cylindrical and the cones are conical. Cones like a cone. Yes, you know that. So that's basically what it is. So these structures are going to be located on the macula and the fovea centralis. So that's when we have all these little receptors for color and white and black and white. So if this part of the retina, remember we talk about in medical terminology, retinal detachment. If the retina detaches, meaning falls, like the inner layer kind of collapses, it's going to be bad because the rods and the cones, meaning the macula, and the fovea centralis is going to be there. It's going to be covered. Light is not going to go through. It's like deflating a balloon. How are you going to see through in the middle if they are collapsed? Not good. They are like sandwich. You're not going to be seeing anything. The light's not going to be able to pass through. The retina is detached. The vitreous humor is not there. So if that happens, it's because problems with the vitreous humor, meaning that liquid on the back, this gel-like substance on the back, this thick, viscous, if you will, substance in the back of the eye that makes the shape of the eye is losing is the amount of substance. So now that's getting flatter and flatter. It's like deflating a balloon. It's like you're having a one of your tires get flat. That's the same. Not good. You can drive. Okay. Any questions about these photoreceptors, rods and cones? Remember, rods, white, black and white vision, cones, color. Okay. Lifespan changes. What are we trying to tell right here? Due to changes in life, age, as we age, we start losing all these receptors. See, these receptors works really good when we are young and healthy. So if you're sick, wow, you're gonna lose these receptors earlier in your life. Or you were born with a condition. But here are conditions that you lose functioning of your structures due to age. So let's talk about this condition that when you lose your hearing because of age. It's called presbycusis. Presbycusis is a condition of age-related hearing loss. That's basically what it is. Presbycusis. Presbyopia is age-related visual loss. So for me, after 40s, and for some of other people that you might know, if you wear glasses, let's rewind. I never wore glasses before until now. If it has very little letters, I'm not gonna be able to see it, I have to wear glasses. Anything else I can see it, not a problem. But if you start wearing glasses after a certain age and you never wore those glasses before, that is called presbyopia. Be careful, don't mix it up with myopia or hyperopia, because these conditions are early age related. So if you see someone like a little kid, right? Doesn't matter, boy, girl. You see them with glasses, they have a condition not related to age. They were born with a condition that is a hereditary condition. Maybe your dad, your mom wear glasses. So fortunately, they pass it to you. So that will be presbyopia. Remember, this is age related. You weren't wearing glasses before, now you are. So that is because of age. Later on, not at 5, not at 6, not at 10, not at 11. No, it has to be after 40s. That's age related, whether you lose your hearing or your vision. This is another term that was very commonly used during the pandemic. Anosmia, age-related smell and taste, loss of olfactory receptors. Remember, the olfactory receptors or the receptors of smell are directly related with the taste receptors. Remember, when you smell something good, somebody's cooking something delicious, you pass by a restaurant, a bakery, whatever, they serving, preparing some food, and you smell something good, your mouth starts salivating. And you develop these craves that says, oh my God, I feel hungry. I want to eat that. Sometimes we actually buy something because of the smell. Says, oh my God, I wasn't thinking buying that today, but smells so good. I'm going to buy it and I'm going to eat it. So these chemoreceptors are also, fading away as age, damage them. That is called anosmia. And that was one of the signs that we look for, or not the signs, let's say for part of the patient, the symptoms that we asked the patient, and everybody was like, oh, well, if I have the flu, usually with the flu, you don't lose your smell or not your taste, because the taste is a little harder to lose it. So when you say, oh, no, I eat something that has no taste. What do you mean I have to taste? Oh, well, probably you have this condition. So those were some of the symptoms that we correlate to the condition during the pandemic. So we heard about those. We didn't hear about anosmia or anosmia. Remember, A means no, without an. Osmia means smell or taste. So that's basically what it is. So this is related to age, not to the pandemic, not to the condition, but it was an example for you to understand that when we lose smell, not because you're wearing glasses since you were a little kid, now we're going to call it presbyopia. No. So we have to put things where they belong. So if it was related to age, it has to be after a certain age that you develop this condition. I'm hearing perfectly right now. Later on, probably ain't happening. Something is gonna happen. If I last longer, maybe my lose my hearing, not completely, but partially, because that happens. And this is important for you because when your patients comes to your office and they telling you, hi, excuse me, good morning, I need your help, or I need to make an appointment, or I have this problem, and you talk to them kind of slow, because not slow, like let's say low pitch. You don't want to scream because patient privacy, right? There are many patients in the waiting area, someone next to the patient on in line waiting for them to be seen, something like that, or to register. So you want to be nice, and you said, "Oh, sir, can you tell me what is the reason?" And you tell it in very soft way without raising your pitch. And then says, "Oh, I don't understand. Speak louder." And then you scream. It's because they losing their hearing. They speak very loud because they think that you are not hearing them, because they have the same problem. They want someone to speak very loud to them so they can hear it. So don't get it personal, because this is important for that reason, because it's applicable to the workplace, that we understand. If the person is having troubles trying to read something, to fill out a form, it's not because they don't speak the language, they don't understand the language. It might be one of the reasons, but talking about this subject is because probably they cannot see small print. So offer your system. You see that they're spending too much time trying to read, and you see that they put the paper right there on their eyes. They are having problems, and they are not, they probably didn't have the prescribed glasses, or they don't have it, or they forgot them. So you have to offer your help. Hi, Mr. Mrs. Smith. Do you want my assistance? Do you want me to help you off to fill the form for you? You're just going to ask the questions and you fill in the information. Sometimes they are embarrassed to tell you. Some people don't like to wear glasses. Do you think that I like to wear glasses? I don't wear them. I don't need them just to walk outside, to see talk. No, I just need it when I see very fine print. Other than that, I don't need it. And sometimes my eyes are really good that I don't need it, not even to read fine print. I can read everything in my phone. Sometimes I cannot. So once again, sometimes we feel embarrassed and we don't like it. Some people don't like glasses and they don't want to wear them. They don't want to carry them. But it's not our job to go there and kind of, lecture them, school them what to do. Remember, these are your patients. These are older people. Probably they're going to be older than you, regardless. So independently, whether they are older than you or not, we just need to be professional, very polite with our clients, and understanding all these conditions is going to help us to do that. So just because the patient is screaming at us, they're not doing it because they want. If you see that it's an old person and they are talking to you loud, and you said, oh, kind of chill out, relax, mister. Don't scream. I'm right in front of you. You don't need to scream at me. It's not that they're screaming, it's that because we need to speak loud to them. They think that they also need to speak loud because they think that they're not going to hear you. Remember, they have problems with hearing. I know when I'm speaking loud. You know when you're speaking loud. They don't because they are losing all these receptors. So they speak louder and they think that they are normal pitch. Think about it. So we need to understand all that. Okay, and here you learn one more term because if a patient says, listen, I have problems. When I eat something, I have no taste. I don't know what's going on. So then it might be a condition. It might be done, it is age related. So you're not gonna give no advice to your patients or diagnosis to your patients, but you understand what the patient is there for. So when you see anosmia as a diagnosis, presbyopia, presbycusis, you're gonna say, wow, I understand what this patient has because you already know some stuff. Any questions about this age-related? Once again, due to age. We're going to talk about those things that are age-related, but not when you grow older. That's simply because at any age, it can happen to you. Like myopia or hyperopia. Okay? So I'm pretty sure that you heard about myopia. I'm pretty sure. Now, I don't know if you know the definition until now. You probably never heard about hyperopia or nearsightedness or farsightedness. So myopia and nearsightedness is the same. So one is a medical term, the other one is a layman term that, well, usually we don't use it much. Hyperopia or farsightedness is the same. So what is exactly myopia? Very simple. Without technical wording, you're gonna say that whenever you can see close objects more clearly than objects that are far, then you have myopia. So where close objects may be seen more clearly, myopia, because myopia, remember, near, something that is right there. But you have this all twisted. Because before I took medicine, I thought that myopia was someone that cannot see something that is very small, that is very close to you. But no, it's because, well, yes and no. Is that you gotta get very close to look at something so you can see it clear. So let's say a child that has myopia and you sit then on the back of the class. They're not going to be able to see anything that is going on the board that the teacher is writing down. Or if there is a PowerPoint presentation, they're not going to be able to see anything. They're going to strain their eyes trying to, to look and to see, and they start blinking their eyes, squinching their eyes, trying to get to see something, but they cannot do it. And they lean forward to get close. What they do develop is a headache. And of course, they're not going to be learning. And so that's the way that we know when the child is brought to our office and the parent says that the child is not doing good in school, that the child has headaches. But we need to know a little more further and try to figure it out what's going on. So they don't say that they cannot see. The parents do not know. They said that their child has headaches. Then when we start doing the investigation, we ask, well, to read something there, we see that they're not going to be able to do it. And how, the muscles of the eyes start clenching, contracting, and the child kind of leaning forward to see more, to put something very close to their eyes. So that's basically what it is. Hyperopia is the opposite. Remember, when we have something that somebody can see something closer but not far away, we have something that can see far away but not closer. So that's hyperopia. Where distant objects may be seen more clearly than objects that are nearby. Think about this. Some people can see far away. You can see the light 2 blocks away from here. You can see that building far away. Some people cannot. Some people 1 block farther, they don't distinguish. Everything is kind of foggy, hazy, blur. So how do we correct all this? Glasses, glasses, glasses. Well, of course, not for anosmia, not for presbycusis, but for presbyopia. If I'm losing my vision due to age, glasses. If I have myopia or nearsightedness, glasses. If you have hyperopia or farsightedness, glasses. So one of the ways that you can understand this is not that they're going to ask you what is myopia, what is hyperopia, but yes, how do you correct this problem? If you have a vision problem, whether myopia or presbyopia, whatever the case may be, how are you going to correct it? Glasses. Glasses. If you have presbycusis, which is age-related hearing loss, how you correct it? Hearing aids. That's what we have for it. For anosmia, sorry, there is nothing to correct that. Well, they will not ask about that. So that's basically what is important. So keep in mind that presbycusis is age-related hearing loss, because sometimes comes in exams. Okay, any questions? No questions? Okay, listen up. We covered a lot with this chapter. It's very complex. I don't want you to have nightmares tonight thinking about the eye and the ears and taste and glasses and rods and cones, pupils, white part of the eye, the color of the eye, the retina, the sclera, none of those things. So I just want you to go peaceful to sleep. And tomorrow is going to be another day. We're going to cover another chapter tomorrow. So for now, we're going to leave it like this. I know you are very upset, but hey, I'm been talking about all these for 4 hours, I guess. So we need some rest, don't you think? If you agree, let me know. If you not agree, well, I sacrifice myself and we continue with the next chapter. I didn't hear anything. I didn't hear anything from anyone. So we continue. I believe that if you quiet down, it's because you want to continue with another chapter, right?
No, I agreed. We should leave it here.
But it seems like Mercedes is the only one that agree. What about anybody else? The other
Girls,
ones.
come on, girls.
Oh, yeah, do something because otherwise.
Agree,
I agree.
agree.
Let's
I am
go.
Okay,
agreement too.
yeah. Please participate because otherwise I'm gonna say, oh,
Let's
well,
go
the
home.
professor
Agree.
says, if it, the professor says, okay, who wants to go home now? And he says, oh, we didn't say anything, and he just closed the portal, and we were hungry for more. So don't get me in trouble, guys. All right. So good night then. It was fun. I hope you learned something from this chapter. It's very interesting, believe me. If you don't learn for your workplace, well, at least you learn for yourself things that you need, just in case we go through all these, because all of us are going to go through these changes. All right. So good night. Thank you for attending the class. Thank you for participating. See you tomorrow, same time.
Good night, everyone.
Good night. Good night.
Good night. Good
Good
night. Good
night.
night.
Take care, guys. Enjoy it. Get some rest.